look at it. I don't want to have to go through another place. So you're going to decide. It's just questions that I don't think are after you have this. Right. Yeah.
Alrighty. So fixed prosthodontics. This is lecture 14 in the fixed book, in the lecture book.
You're tripping everybody up today.
Yeah. Keep you on your toes. Alright, so the difference between fixed and removable. Fixed is staying in the mouth, whether it be a bridge, a crown, an implant. All these are fixed prosthodontics. Okay? They're staying in there. They're replacing one or more teeth, but they're not. They're staying in the mouth. Another name for it is crown and bridge, they call it. Some are direct restorations, amalgam or composite, are fabricated in the mouth, while the material is soft and adaptable to the tooth. Indirect restorations, which are crowns and bridges, we know have to be made outside of the dental office, okay, in a lab or in our CEREC milling machine. And then you bring them back and you bond them onto the tooth, or somehow you cement them onto the tooth so that they're staying in there. So the restorations are bonded in place. Examples of indirect restorations are crowns, inlays and onlays, which will cover veneers. Everybody's heard of veneers. They're just porcelain facings. And fixed partial dentures. Okay, fixed partial dentures is another name for a bridge. Okay, so a partial denture, you're replacing a missing tooth. So it's just like a partial, like those little spiders, but it's cemented in there. Okay, so what are the types? You've got crowns, and you guys have charted, so you know that there's metal crowns and porcelain crowns and partial crowns and all kinds of crowns. So the first one is an FCC, full cast crown. And when you chart it, it's all colored, right? So right there, needed, or right here, done. So it's a full cast crown, whether it be gold or silver or any other alloy. It's made of gold, metal, and designed to cover the entire anatomical crown of the tooth. Okay, not just part of it. It covers the entire anatomical crown. Looks like that. Okay. Here are the stone models after they've been prepared. Again, you can see how they've, in order to do a crown, you've got to take shave the tooth down from the sides and from the biting surface to make room for that gold or the porcelain. You can't just stack. You can't just add gold or porcelain to this, because when you bite down, guess what? You're going to be too big. You have to shave it down and then make it out to the original size. So again, teeth are shaved down and then they're cast into the metal like that. Okay, you've got porcelain fused to metal, so PFMs, a full metallic coating underneath, and then you have porcelain stacked on top of it, or composite. Can be stacked on top of the porcelain, or on top of the metal. Okay, so here you've got the porcelain on the outside, and this little gray line through here, this is metal. So you have like a little metal coping, and then porcelain or composite around it. This is what they look like on the underneath. So this is a PFM, porcelain fused to metal crown. Okay, and that's kind of what they look like sometimes in the back of your front teeth, when, especially if a patient has a real heavy bite. Sometimes you want them to rest on or to hit on metal and not porcelain to minimize the stress on the porcelain if you can't get enough thickness of porcelain. Porcelain or any ceramics, they're strong, but that you have to have a certain depth or thickness. If you don't, they'll key to this machine that we have. You need about 1.5 millimeters to 2 millimeters of thickness. If not, your crowns are going to start breaking. Okay, so the materials are strong, but you have to prepare to allow the material to do what it's supposed to do. So again, same thing, a model there, and then you have your porcelain crown, porcelain fused to metal crown over it. Then you have partial crowns. Okay, so a partial crown is any crown that does not cover the entire surface of the tooth. Okay, it covers more than 3, but not all the surfaces. Okay, so you can have something like this. This would be a partial crown. Kind of a funny looking one. I don't know why they did it that way, but they did. Or you can have, let's see, looks like here, this is natural tooth, this corner right here. Here's the margin that comes through here and through here. I don't know if you can see from way back there, but it's through here. And this is a partial gold crown. Okay, inlays can be made from gold or porcelain or resin. Inlays can replace mesial, distal, occlusal, buccal, and lingual surfaces of posterior teeth, but they do not cover cusp tips. Okay, so it's like an MOD. It's like, but it's made in the lab, and then you come back and you cement it. So that's an inlay. Okay, it doesn't cover the functioning cusp tips. It's just you can have an MOD inlay, an MOL inlay, as long as you don't cover the cusp. Okay, so here you would have an MO inlay. Inlay just means that you're taking it from somewhere else and you're inlaying in, like guitars have inlays of material on to decorate it. They'll have wood. You can have wood, like furniture, and they have an inlay of wood inside to kind of make it look pretty. Well, this is an inlay into the tooth. Okay. Here, a gold inlay. Here's an MO inlay. It does not cover the cusp. A DO inlay, MO inlay, DO inlay. Okay, so you're not going onto the cusp. Once you go over the cusp, and the reason you would go over the cusp is if this cusp is weak and potential to break, then you're going to cover it, and then it becomes a onlay. Okay, as soon as you cover that cusp, it's an onlay. And you can have an MOB onlay, MODL onlay. Once you cover that cusp, so if this cusp broke, then you've got an MOB onlay, because you're covering, onlaying that cusp. Okay? So it includes at least one cusp coverage. You can cover 2 cusps, you can cover 3 cusps, like that. Like this partial crown that we showed here, you could call that a MODBL onlay. Okay, you left that one and that one, but these are onlayed here. Bless you. So this is could be a partial crown, or it could be, you could call it an MODBL onlay. Okay, and even that one there. So they left, I don't know why they left these 2 little bits of enamel, but they did, so that's an onlay. Here you have a DOB. Yeah, DOB. Porcelain, used the CEREC. Again, you can see it right here. And just bond it in. So again, you're onlaying this cusp, these cusps are left alone. And that's the good thing about CEREC and the new bonding, is that you can be more conservative. You don't have to cut down the tooth, all the way. It's nicer for the tooth. The less trauma you do to the tooth, the more likely that tooth will survive long term. If you cut every tooth for a crown, the likelihood of that tooth needing a root canal later on or then, it goes up. So if you can prevent or be more conservative, it's nicer for that tooth. Because if you think about it, any restoration, you're looking at it, the lifespan or average lifespan is about, hopefully 10 years. In 10 years, you probably will have to replace it for whatever reason. Decay, it broke, whatever. So if you're 25 or 30 and you do an onlay versus a crown, say in 10 years, then you'll be 45, and then maybe something breaks and you do another onlay. If you do a crown when you're 25 or 35, then when it breaks in 10 years, then what are you going to do? You can do another crown, but again, it's more trauma to the tooth. So the less you do at a younger age especially is better for your patient, better for the tooth. Okay? Because again, it's not a matter of fact of if it's going to fail, it's just when it's going to fail. No matter how good a dentist you are, eventually your work will fail. Just because
There are no permanent solutions.
no, something will happen. So here's an inlay, here's an onlay, and here's your full crown. Okay. Veneers. Okay, veneers are, and these are just little show veneers. It's just a porcelain facing on the outside of your tooth, or to cover stain, to cover rotation. It give you a little bit of a cosmetic alignment. If you don't want to have braces, you can sometimes slightly modify the teeth and just put porcelain facings. I think this is in your book. You know, if you've got a chip or staining, again, you roughen it up, modify it a little bit. You do have to remove about 0.5 millimeter of enamel from the face. Okay, again, if you just add porcelain to the outside, they're just going to look like chiclets, you know, too fat. You've got to thin it down and then bring it back to ideal. Okay, you can't just add. I take that back. If you have a patient that has, some patients will have real thin teeth, or their teeth are kind of tipped back a little bit, then you may be able to add without taking off anything, because you're getting them out to a little bit. You're trying to give them a little bit more lip support, maybe. Then you can do that. But on a patient that's, you know, have normal teeth there in the front that are tipped out or whatever, you can. You've got to shave them down. And again, after you rough them up, you take an impression, and then you get those. I think those are plastic. They're not real ones, but at least it gives the patient some idea. And then you get them back, and you bond them on. Again, this is kind of what they look like. Kind of contact thin, they say. And again, for heavy staining, you can veneer teeth, and they do make a difference. For crowding and chipping and staining. Fixed partial denture or a bridge. Okay, so another name for a fixed partial denture is a bridge. That may be on the test. Fixed partial denture is a bridge. I don't know why it doesn't have a star, but for some reason it rings a bell. A fixed partial denture, a fixed prosthetic device that is permanently attached to the teeth remaining in the mouth, which can replace one or more missing teeth. But again, the longer you get, you can probably do 4 teeth, maybe. Probably from the canine to the first lower molar, replacing the 2 premolars. But going from first premolar all the way to the second molar, it'll work, but eventually the teeth are going to fail on you. Again, abutment. You guys all know what the abutment is. It's the anchor. You'll have a mesial abutment and a distal abutment. The pontic is the missing tooth. Okay, so you can have 1, 2, or 3 pontics. Retainers, sometimes you, and I'll show you what they are. I'll show you a picture. If you have like a congenitally missing front tooth, lateral usually, instead of preparing the teeth next to them for a fixed bridge, especially on young kids, you can do a cast retainer, which is just a porcelain lingual part that's bonded on, and then on that you hang a tooth. just on that one part. It's called a Maryland bridge, and I'll show you. Okay, so it's just a retainer. It's kind of it's not a, it's an extension of the pontic over onto the adjacent tooth to the abutment, but you're not cutting down that tooth as an abutment. I'll show you. Connectors are just where they're soldered together for the missing tooth. So again, here's a conventional 3-unit bridge. You've got the abutment, and the pontic. Okay, again, abutment, pontic, and you glue it on. And it would look like that. Okay, so again, same thing, fixed partial denture. When you're missing a tooth here, you prepare those teeth down, you shave them down, and then you glue those in. And same thing here. So those are bridges. Okay, post and core. If we have a tooth that has had a root canal and we don't have enough tooth structure to put a crown on, then we do what was called a post and core. It's basically a little rebar post that we put inside the tooth, and then we bond material on it to shape it and give us something to put a crown on. If the tooth is broken down to the gum line even, you do a root canal and you put posts in there, and then you build onto those posts, and you anchor on, and then you have something to build up on. I'll show you. The post can be either metal or resin, again, for an endodontically treated tooth. The core is just the build-up material. Okay, you're just giving yourself a bulk of material to put a crown on. Okay, so here's what it looks like. Okay, here you see the root canal tooth. Now this one doesn't have a post. This has a core buildup. This has a post, and this has a post and core buildup. Okay, so this is a core buildup. This is a post and core buildup. Okay, and there's a difference because when you bill it out to the insurance, you have to charge. There's an additional $40, $50 charge for that post that you're putting in there. Okay, so you have to bill out post and core, or just the core. Okay. You can do just the core buildup, and now with the bonding materials that we use, I use posts very infrequently, unless I have nothing to grab onto, because the materials are so good now that they really grab on. Before, you had to put posts, and then you had little pins that you would drill into the dentin, and anything to get it to stay. But now you use them rarely. But for coding purposes, you have to code different, or else you won't get paid, and your doctor will be mad because you put a core buildup and not a post and core. So he just lost $60, or the cost of $60 for that post. That's what it looks like in the mouth. Okay, you can see the post right there. Okay, so without that, the doctor didn't have a wall over here to put a crown on. Okay, so he had to put that post, anchor that material onto that post. That's what it looks underneath. So on something like this, where you don't really have much to grab a hold of, you can't put a crown on that. I mean, your tooth is going to be that short by the time you shape it. There's nothing that's going to bond. Okay, so the teeth have root canals, and now you can lengthen them, and now you can put a crown on those. Okay, so that's got a post in there and a buildup material, and you shave them down, and now you've got something to put a crown on. Okay, implants. Everybody's heard of implants. It's a replacement of natural teeth, which utilizes a titanium metal device embedded within the patient's bone. Okay, so they kind of look like that. Those are implants. This is a bridge, 3-unit bridge, and this is a single unit implant. So normally I don't place implants yet. With this new technology that's coming out of the cone beam, hopefully, in a year or so I'll be placing them, but we've got to get that technology in our office. But again, it's titanium. The posts are titanium, just like a hip, like a knee, like a shoulder. It's the same material. Okay, the body in most cases does not reject it, so you place it in the bone grows around it, and then you can put a crown on top of it. Osseo means bone. Integration means just the growth of bone onto the implant. So it basically becomes a part of your bone because the bone grows into that implant. It takes usually 3 to 6 months for the bone to grow, and then you can place the crown. Okay, so the parts of it, you have the implant, which is the metal that goes inside the bone. Then you have the abutment. Okay, so the abutment, once you have the metal, is down below the bone, then you put that little, if you take the crown off, you have a little extension from the abutment, bringing it up above the gum. I'm sorry, from the implant up above the gum. That's the abutment portion. Okay, and then you have the crown that goes over the abutment. Okay, this is important because you will have patients that have implants and they'll say, how do I take care of them? And you don't want to use any metal instruments around them because you scratch the abutment and that causes problems. When we clean or probe around the tooth, we use Teflon coated plastic or a plastic instrument to clean around it. And usually all I do when I have a patient that has implants and they're in for a cleaning, I get super floss, which is floss that has like a little gauze, and I just thread around it and I just kind of shoe shine all the way around the implant. I don't even get in there with instruments. Usually if they're kept pretty clean, you don't get much harder to grow on them. But you just have to get in there and make sure nothing's staining on them. Polishing should be done with a rubber cup and gel rather than an abrasive prophy paste. I normally, when I'm doing my prophy, I don't even prophy them. I just skip them, go to the next tooth. Again, because the prophy has abrasives, you don't want to scratch down on that implant and get stuff sticking to it. Okay, so I think this is fill in the blank. So make sure you know what we're using. You don't want metal instruments. You want Teflon or plastic instruments, and you want to polish with gel and a prophy cup. Okay, so for an implant case, again, you're missing a tooth. The implant is placed by the surgeon or the general dentist. You put the abutment on top of the implant with a screw, and then you put your crown. Okay, this is kind of what they look like. This is the implant. These are the abutments up on top. And the abutments, depending on what you need, you get them in this, depending on where the implant goes and the positioning, you can get them angled, or you can cut them and get them custom made. Some of these machines can cut your implant abutment now. There's just a lot of things going on. So here you have an implant and implant supported crown there. Like that. And the radiograph, they look like that. This is the best way to go now. It's pretty much the standard of care. I mean, that's what I would want on me. That's what I would want on my parents or my kids if they lost a tooth. I wouldn't want to cut, virgin teeth to put a bridge. Why? Now, if this tooth already had a crown and this tooth already had a crown, and they lost this one, then yeah, they already have crowns. But why sacrifice teeth if you can go? It takes a little bit longer because you're going to need to go 3 months of healing before you put it on. But the benefits are that you're not tying these 3 teeth together. Because again, if you're averaging 7 to 10 years, in 7 to 10 years, you're going to have to redo that. You're going to have to re-prepare these in 7 to 10 years. The possibility or the risk of these needing root canals the second time you drill on them or the third time you drill on them goes up. Root canals don't always work. They do fail. So eventually you could lose this tooth. So why even get into it? It's going to cost you a little bit more to place the implant. But long term, I think it's less expensive. And if this breaks, if your crown breaks, then you're just replacing 1 crown. If your bridge breaks, then you're replacing 3 crowns every 7 years or 10 years instead of 1 crown. So long term, it's more cost effective to do an implant. Short term, it's a few $100s more. But that's kind of what they look like in the mouth. This is before uncovering. Here you have them uncovered, or here's the impressions that they're taking. You uncover them and put the abutments, and then you cement the crown. I heard. Must have learned. Questions? You guys are good learners.
Give us good notes to go off of too, so.
Giving you the answer, that's what I mean.
I know.
All right, so the lab. This afternoon, Mike is going to be here again. He's going to bring some materials, impression materials. And again, we're talking about materials that give you more what? Precision, okay, compared to alginate. Okay, alginate, whenever we're working, we're doing crown and bridge, we need, down to the micron we need. They're very precise. And now with the CEREC machine, we don't take an impression using these materials. Now we just scan, and some of you guys have seen a scan and you've seen it mill. And the precision on these machines is just incredible. But if you're doing it where you're taking impressions, the reason he's going to talk about polyvinyl siloxane, and you guys have heard that. Polyvinyl siloxane. You guys have heard of alginate. He's probably going to talk about polyether material, and that's, some of them have benefits, some of them have, some of them like water, some of them don't like moisture. So he's going to talk a little bit about the differences of those and why some doctors like some and some don't like some. But he's going to give some good information. Then he'll let us play with some of those materials, and we'll take some impressions on the mannequins. Okay, so procedures for a full cast or full porcelain fused to metal crown, or an all porcelain crown. Okay, so again, before the CEREC machine, it's two impression or 2 appointments. Patient comes in, anesthetized, we prepare the tooth, take an impression with those materials, put a temporary, the patient goes home for 2 weeks, patient comes back, numb them up, take the temporary off, clean it out, cement the crown. Okay? Same thing. Okay, so what do we need? Basic setup, cotton rolls, gauze, all the normal. We need anesthesia. We've got to numb the patient up. High-speed handpiece and slow-speed handpiece. Diamond burrs. You guys will see the diamond burrs. A plastic instrument to pack the cord. We'll show you the cord. Cement, spatula, tooth shade guide to pick the shade of the porcelain. If we're going to do a core buildup again, we need the buildup material. Gingival retraction cord, we'll talk about that. Polyvinyl siloxane, or whatever impression material you're using, polyether or rubber base or anything of those that you're using. A bite registration material, and whatever you're using to temporize the patient. This is our setup here. Okay, I got my high speed, slow speed, cotton rolls, gauze, and my basic setup here. In the back, I've got my anesthesia, my porcelain shade guide, my diamond burrs, and my extra burrs, cotton rolls in the back. On Yessie's side, here we have our impression tray. This is called a triple tray. If we're just doing one tooth, or maybe even a bridge, on one side we can use these triple trays, and you're taking, the good thing about these trays is that you're taking an upper and a lower impression at the same time. Okay? Prepared on the bottom, I inject on the bottom. You're going to load this tray, and you'll learn how to do it. You're going to load it, you hand it to me, you put it on, you have the patient bite. So it registers the upper and the lower bite in one. So you don't really need a wax or a bite registration, because it's already on your impression. Sometimes I'll see that the patient didn't bite down all the way, they've been crooked, then I'll take a bite registration. some patients are difficult to get an impression, and I'll take them by registration. So you've got your, what's this?
Primer and bond.
Which is called the what? Primer bonding system. So this is the bonding system. Alcohol, this is Hemodent with cotton pellets or the cord. This is your temporary cement, little mixing spatula. This is Triangle, cotton rolls, cotton gauze. These are your tips for your syringe. Okay, you've got all your guns ready. Got your temporary material, your impression material. Or, I'm sorry, this is your build-up material, your temporary material. And we'll see those setups. Okay, so the first thing we do, numb up the patient. This is on the test. A pre-impression of the tooth is prepared. Is taken using polyvinyl siloxane material in a triple tray, an impression tab, or silicone putty. We use an impression tab here. Okay, and you'll make your own impression tab, and you'll make your temporary. After this impression is completed, it is set aside until after the preparation, and it's used to make the temporary crown that the patient is going to go home with. Okay, and you'll make your own temporaries today. So this is what we do here in the office. You can use a regular impression, but we use this. So you got warm water. You put your little button in there, and it softens up and turns clear. And then you kind of knead it and spread it out, soften it up, and kind of stretch it out if you're doing one or two teeth. And you want to go one tooth in front of, one tooth behind of the one you're working on. Okay, so if we're working on tooth number 20, when you put your material here, you're going to go on tooth 19 and on tooth 21. Okay, because you want when number 20 is cut down, you need to rest on the teeth in front and behind so that it has something to relate to. Okay, so you go one tooth in front or behind. So here, say they're doing tooth number 24, then they go a little bit, it doesn't have to be just one tooth. You just want to go past it so that you can seat it afterward to make your temporary. So you put it in there when it's soft, wet your fingers with saliva or with water, and just kind of mold it over the teeth. Don't thin it down too much. Just kind of shape it and let your fingers just kind of smooth it down. Okay. Then you can blow a little bit of air or light little air water mist to cool it off, and it'll go from being clear back to I think we've got white ones right now, so back to white. So it will go from transparent back to white. These go from light blue, and then they turn like you can see through them, and then when you dry it, you can't see through them. Okay, so it looks kind of like that. So we're going to squirt the temporary material in there to make your temporary after it's prepared. So we take a shade before we start to work on the patient. And why do we take a shade before we work on the patient and not after? Because when the patient is open for whatever 20 minutes that you're working on, they're open and you've got high-speed suction there, what's happening to the teeth? Blowing air on them, and you've got your mouth open. They dry up. As they dry up, they lighten them. So if you take a shade after you've worked on them for 10 minutes, it's going to be light. Yeah. So you want to take them, as soon as you numb them up, you take your shade. That way you're going to get the most. And a shade is you're going to be in the ballpark. They're not exact. Unless you're doing the front teeth, then you custom shade. Sometimes you send them to the lab so they can do a custom stain. But in the back, if you're close, patients don't really need to be exact. So it's white somewhere in the ballpark. So then we prepare. We're going to cut that tooth down. Get our margins. Okay, after the tooth is prepared, the gingival tissue needs to be retracted away from the prepared tooth so that the detail impression can be made of the margins. Okay, so this is where we use, it's called retraction cord. You guys will pack retraction cord on our models today. Basically, we're putting a little string between the gum and the tooth, after it's prepared, before we take the impression. Okay, so that we're pushing that gum tissue away. We let it sit for about 5 minutes. Then you pull the string out, and that gum tissue is still retracted. And when you squirt in that impression material, it flows into that little crevice that you created. Okay, so you just retract. Sometimes, if the gum tissue is up on the tooth, then you won't get a good impression. Okay. Okay, so here they are kind of packing the cord, and that's why you need a plastic instrument. So even though it's a plastic instrument for composite, we use them to pack cord as well. So it's called, when you're doing crown and bridge, the plastic instrument is called the cord packer. Okay, but it's the same instrument. Yeah. But it's the cord packer when you're doing crown and bridge. They do sell cord packers. And some of them have like little ridges on the edge so that the cord doesn't slide. But it's the same instrument. But you can get different manufacturers. So there's the cord down in place. And then again, you let that sit for 5 minutes. It's preventing bleeding. If there was any bleeding from trauma, from cutting down there, it'll stop the bleeding. Then you gently pull it out, and hopefully it doesn't bleed. And then you squirt the material in there. So we select whatever material and tray we're going to use. Again, we've got triple trays, and I think Mike will bring some. Again, these are triple trays. You've got for posterior, wide body. You've got extended quadrant. You've got anterior trays, sideless trays, whatever you need. We've got, I think the ones we have are Premier, the manufacturer, and we've got anterior and we've got quadrant. I don't think we have it wide, but we have the posterior. Then you have, again, these impressions trays that are stock trays. Again, quadrant trays and lower and upper and extended quadrant. Again, this is a triple tray. You can see how the patient bites down onto it. Okay, so prior to the impression, the retraction cord is removed by the dentist using cotton pliers. And then I'm going to start, if I pull the cord out and I see that it's not bleeding and the tissue is retracted and I can see the margin clearly, one of those guns that you have on the setup there is a flowable, it's an injectable material. So I'm going to squirt it in and it just flows into all the little crevices. So I fill around kind of like an ice cream cone, just kind of come up. And as I'm doing that, you're mixing or you're loading the tray, okay? And when you work these guns, you've got to squeeze all the way down. Don't go halfway and then try to let out because it won't work. You've got to squeeze all the way down till it clicks, and then you let it out. And it's tough sometimes. It's a heavy body. I'm squirting the light body. I got the easy job. You've got the heavy body, which is tougher to squeeze. But we're on time here, especially right now that it's hot outside. It sets up quicker. Okay, so if you don't hurry up and I put my material and yours is setting up, when we put them together, they don't mix. Okay, and then when you take it out, you can see a definite line that they didn't mix. When you see them together, they should kind of mix together and become one. But if the materials are setting up, then they won't do that, and it's not going to fit. So it's really critical that when I start squirting, you start squirting, and as soon as I'm done squirting, you should be handing me that material. Okay, and we'll work on that. And I'm sure Mike will bring some stuff, and he'll probably go over some of this stuff. So here I am putting the flowable on there, and there you are squirting. Now this is an electronic thing. You don't have that, but you just press a button and it goes kind of like, yeah. And you may go to an office that has it. Okay, these are usually prosthodontists, and that's all they do, crown and bridge all day long. They have these automatic things. They put these big dispensers and you just click a button and it's just kind of like nacho cheese, just squirts it out, and it's real easy. You just load the tray and hand it over. we've got the guns, it's a little bit tougher, but again, you just need to make sure you fill it and then hand it to the doctor. And on the triple trays, again, because we're registering the upper and the lower bite, you do on one side and you flip it over and you do the other side as well. Okay, so you've got to do both sides. Okay, and then they bite down into the tray. Okay, and this is what we need to get. You can see the definition of this isn't mine, but of the preparation right here. You can see good detail. Okay, the retraction cord where you can see the flowing material that just kind of fell down into the crevice. It's got to be clear. So you send this impression to the lab, you better expect a crown that's going to just drop in and the margins are perfect. They've got no excuse to give you bad quality product if you send them a crown like this, or an impression like this. Okay, and if you do get bad, then you've got to change labs. And I know Dr. Cervantes and myself, I mean, we're really picky about our margins and stuff, and you know, this is normally what we send to the lab. You send something like this where you start to, I don't know if I got my margin here. You know, you got a good margin here, and it's good here, good here, good here, but over here, I don't know. Well, if you can't see it here and you send it to the lab, you think the lab's going to see it? They're just going to give you a margin wherever, and then you hope it fits. Okay, here, I mean, you can see, you don't even know where the margin is. Okay, so this is what you want. You want nice. You can see how it mixed right here. It just becomes one. They talked in seminars up in Las Vegas. Now, because you're doing digital, you don't have to worry about this. They made fun about it. A dentist, I think from Florida or something like that. It's always Florida. From Florida, and he uses Glidewell, which is a good lab. We even use Glidewell as from California, but they, you know, Glidewell does their statistics on the doctors and you know, how many remakes a doctor has, you know, throughout a month or a year or whatever. And they say, you know, this, actually they showed his case, he uses like very little impression material. He only sends like that much. You know, he doesn't give like a whole arch or anything. He's very stingy, I guess. He uses that much, and usually impressions that they get are like this. You know, but he says he's got like no remakes. You know, he never remake. He makes everything fit. You know, so it's like, I don't know if you want to be going to that guy. I mean, he said, and then they said about, they sent this one case, because sometimes you'll get a case in and it was sent wrong. It was like for another office. So you just call them and say, oh, we got this case, it's not ours, and it goes back. Well, so they sent this case to that doctor in Florida, and the doctor in Florida's case went to somewhere else. Well, that lab somewhere else called them and said, you know, this case isn't ours. Do you have our case? And so they find out that this guy in Florida has. So the next bite registration is taken. The purpose of the bite registration is to record the relationship between the maxillary and mandibular teeth. Many different materials can be used to get the bite registration. Transfer the bite registration material to the dentist for placement. Once the bite registration material sets, move from the patient's mouth, disinfect it, and set it aside. The provisional crown is now fabricated. Take the polyvinyl siloxane impression taken at the beginning, which in our case we'll use those little tabs, and then you fill that with whatever self-curing temporary material you're using, put it back into the patient's mouth, and then once that sets up, you're going to trim it and contour it and check the bite before you cement it. Again, there's many methods to fabricate a temporary. Your role as a dental assistant is to transfer the necessary materials to the dentist as needed, and in some cases you'll be able to fabricate the temporary, and then you can cement it, remove the excess cement, check the bite, and just make sure the dentist checks it. To cement it, you're going to use a temporary cement. You're going to line the temporary, then put it into the patient's mouth after you clean the tooth. Hold it for a few seconds, about 20 to 30 seconds. Allow that temporary material to partially set before you release the pressure. And then give it a minute or two, and then go in there with a scaler or an explorer to remove the excess material or cement. Once the patient is dismissed, then you're going to write the prescription that you're going to send to the laboratory so they can fabricate the crown. You need to make sure you tell them the patient's name, what the procedure is, what they're fabricating, whether it's a full gold crown, a porcelain crown, an Emax crown, whatever it is that you're doing, what shade you need it, A3. You sometimes break it up and draw a picture of the different shades that are needed. Then it has to be signed by the dentist license number, phone and address are also on the sheet. This is the lab that we use. It's Glidewell out of California. Again, you see here, there's a whole bunch of different material types and different types of restorations, and all you do is check the box that we're going to use. And you write here, please fabricate an Emax crown, shade A2 for tooth number 30. And then up here it says what's included in the box, or you have the impression, models. Right here, impression, models, bite, articulator, crown and bridge, or anything else that's included in there. Pictures we'll email. If we take a picture of the patient's tooth, we'll email it to the lab so that they can put it into the patient's chart and have a little better idea. The procedure to cement the full cast crown is as followed. The procedure is performed by the dentist, but obviously we need the dental assistant in there to help us keep the area dry, to mix the cements, and to have everything ready there to cement the crown. This is what's needed. Obviously the basic setup, high volume evacuator, saliva ejector or water syringe, slow speed handpiece, finishing burrs, anesthesia. We do need anesthesia because when you remove the temporary, if the patient is really sensitive, you have to anesthetize the patient to keep the patient comfortable. We'll need a spoon excavator, a scaler to remove excess cement, a plastic filling instrument, final cementation materials, and completed crown from the laboratory. This is kind of what it looks like. Here's some glass ionomer cement, high-speed handpiece, low-speed handpiece with lab burrs, your crown restoration, and anesthesia, articulating paper, and all the other basic materials. Here's our setup. Behind me we have the crown from the lab. Here's the crown on the die. Here's an occlude, which is a pressure indicating spray that I use to check the contacts. I have my finishing burrs. On Jesse's side we have the cement that we're going to use, depending on what restoration we use. This is Panavia F. We've got Reliex. We've got Auto Mix. There's a few cements that we have, so you have to know what material we're cementing and what cement is proper for that material. And that just comes with time and working with your dentist. So this is very important. The day before you have a case that's going to be cemented, you need to make sure you verify that the crown has arrived from the lab, or that it's going to be there the following day in the morning, or just make sure that it's there before the patient is there. I can't stress that enough. You get patients that come in from miles around, from Nogales, from Phoenix, from Vail, from Flagstaff. I mean, we've got patients coming in from all over, and it's not very good for the practice if the patient shows up and to pick up their prosthetic crown or whatever we're delivering, and we tell them, Mrs. Smith, your crown isn't here yet. We'll have to reschedule. So that's not very good. So please always check the schedule the day before. And here we have the receptionist when they verify the appointment. When they confirm the appointment, they make sure that the case is either on its way or already here. But then they're double checked the day before with our assistants. They should be checking the schedule before they leave. Now, it doesn't happen all the time, and if it doesn't happen and we have a problem, then we have a conflict with that assistant. So it's real important that these things are checked. When the patient arrives, you seat the patient. Temporary remove is removed. And again, if the patient, once the temporary is removed, if it's really sensitive, we're going to give them an anesthetic in order to make them comfortable. Once you remove the temporary, again, we're going to have to rinse the tooth and clean it out before we try the other crown. We try the crown, adjust any contacts, make sure that the floss is going through, check the bite, make sure everything looks good. And once we determine that it fits properly, we're going to isolate the area with whatever we need to keep the tooth dry so that we can bond or cement. And again, we'll give you the okay, and you're going to mix the cement depending on whatever cement is used so that we can bond the restoration or cement the restoration properly. Here's one of the auto mix syringes. Again, you're just dispensing the cement right into the crown. You don't want to overfill it because then it all just gushes out and you're just wasting a lot of cement. Okay, here's one that's overfilled. Again, once you try to seat that, everything's going to spill out. And again, you probably could have cemented 2 or 3 more crowns there. So again, you just need to be conscious that it's material that is being wasted, and these materials, you know, are $300 or $400 for a little bottle. Okay, so you need to make sure of how much material you really need. Here's a temporary that's being lined. This is about what you need, maybe a little bit more. You want to make sure you put material on the margins of these crowns so that when you do seat, the crowns are really sealed. Once the crown is seated, hold it down for 20 seconds or so, and then you're going to have the patient bite down on a cotton roll, or some of the materials that we use now, we actually cure it with a light so that it turns into a little gel, and then we can go in there and remove that with our Explorer or Scaler before it fully sets. Here it is. You guys can do this. You want to make sure you have a good fulcrum to go in there and remove this cement as long as it's above the gum line. If you get cement that you can't remove or it's really tough, then call the dentist over and have him get in between the teeth and remove that cement. You just want to be careful you don't gouge the patient. Tell the patient that not to chew anything sticky or hard for 24 hours or so. Then the patient is dismissed. Always tell them, you may have a little bit of sensitivity to temperature for a few days. That should diminish with time. You shouldn't have any sensitivity, constant pain, spontaneous pain, waking you up at night. That's not normal. Any of that, then the patient would have to call us so that we can check.